GI pathology, appendicitis, as well as diverticular diseases. All right, so first we have appendicitis, which is just the acute inflammation of the appendix. Now, what they want you to know is that the main cause is usually going to be due to a lumen obstruction, all right? Usually an obstruction with a calith, which is just a hard stool, okay? So obstruction of hard stool, lumen obstruction by hard stool usually is the acute cause of the inflammation of the appendix, appendicitis. Now, the way that you're going to remember this is that the patient's going to have initial diffuse periumbilical pain. So they're going to say, oh my gosh, I have severe periumbilical pain that's just like diffuse throughout the abdomen. And then as the pain continues to go, it's going to cause irritation of the parietal peritoneum and then localize to the right lower quadrant, which is McBurney's point. All right. So one, the initial diffuse periumbilical pain is due to irritation of the parietal peritoneum. And then after a little bit, it will localize to the right lower quadrant at McBurney's point. And then you're also going to see potential nausea, fever, and then if perforation occurs, you're going to see peritonitis. All right. Now, you can have multiple signs. There's a psoas sign, the obturator, and the Rovsing sign. So psoas sign is when essentially you extend the leg and the psoas bumps up against the appendix, causing pain. The obturator sign is when essentially you rotate the hip externally and bring the foot internally, and that's the obturator sign. It's going to cause pain as well. The Rovsing sign is when you essentially palpate the left portion, the left lower quadrant, and you're going to get right lower quadrant pain. Now, overall, the patient's going to have irritation of the parietal peritoneum that causes the pain. That's very high yield. And the use of the tinea coli is used to identify the location of the appendix. Okay, so they might ask you, how do you identify the location of the appendix? You use the tinea coli or tinea coli to identify the location. All right. So remember, lumen obstruction is the main cause, initial diffuse periumbilical pain, which then localizes to the right lower quadrant, usually due to parietal peritoneum irritation. You can see nausea, fever, and psoas obturator Rovsing signs could be potentially positive. All right. Next is diverticulum. So before we talk about the diverticulum, like kind of the pathologies associated with each, we should kind of just give each one of these a definition. So first is diverticulum. Diverticulum is just a blind pouch. Okay. Now, you have true diverticulum or false diverticulum. True diverticulum has all of the gut wall layers. We're talking about the mucosa, the submucosa, the muscularis layer, as well as the serosa or adventitia, right? False diverticulum does not contain all the layers, okay? So that's the only difference between true and false diverticulum. Now, the false diverticulum has the absence of the muscularis propria, but you will still have mucosa and submucosa outpouching, all right? So it's just a blind pouch that communicates with the lumen of the gut. All right. And that's going to be majority of the diverticulum that we're going to be talking about, or the diverticular pathologies we're talking about. Next is diverticulosis. So diverticulosis is many false diverticula of the colon. So take a look at what it looks like. It's just many false, essentially holes within the colon, and it usually commonly affects the sigmoid colon. So the patient with diverticulosis is going to have a lot of false diverticula of the colon on imaging, mainly affecting the sigmoid. All right. And it's going to be common in elderly people. It can be associated with obesity and diets low in fiber and high in total red meat and fat. Okay. So increase like fat in the diet or red meat in the diet leads to increased risk of diverticulosis. They want you to know that. All right. Now, the patient's often going to be asymptomatic, but if they are symptomatic, they can have painless hematochezia, which is just blood in the stool, seen due to the vasorecta exposure and rupture. So if you do see painless hematochezia, it's due to the fact that the vasorecta, which is just the blood vessels, they're exposed now because of the diverticula, and they start to rupture. All right, and that's what they want you to know about diverticulosis. Now, diverticulitis is when you have inflammation of those small diverticula. Okay, so a patient with diverticulosis is at an increased risk of diverticulitis, inflammation of those small diverticula within the wall. Okay. And the patient's usually going to have left lower quadrant pain, tender left lower quadrant, okay? And the reason behind that is because, once again, we said the most common area affected is the sigmoid colon. Well, where's the sigmoid colon in comparison to your body? It's in the left lower quadrant. So that's why patients will have left lower quadrant abdominal pain. You also are going to see fever associated with this and leukocytosis with a potential palpable mass, okay? Left lower quadrant pain, fever, and leukocytosis are key. All right. Now, the complications are abscess, which can cause that palpable mass, and fistula formation with the bladder, right? And so you could see, once again, pneumaturia, which is air in the bladder. All right. So we have to worry about perforation with diverticulitis as well. It's a common complication that we have to be concerned of. All right. So that is kind of our definition of diverticulum versus diverticulosis versus diverticulitis. All right, so now let's get into some diverticulums that are pathological that we are worried about. The first one is Zenker's diverticulum. Zenker's diverticulum is a false diverticulum. So that means it's only containing mucosa and submucosa, right? Not the muscularis area. And what they want you to know is that Zenker's diverticulum is due to cricopharyngeal motor dysfunction. They will say that, cricopharyngeal motor dysfunction. If you remember the word cricopharyngeal, then you should be able to get all the Zenker diverticulum questions correct, okay? And what happens is you have an outpouching of the area, the cricopharyngeal area. And the patient's usually going to present with these key symptoms. One, foul breath. Foul breath is very, very high yield. They will say the patient has really foul breath. The reason behind that is because as they eat, some of the food goes into that diverticulum, the Zenker's diverticulum, and it just sits there and rots. Okay. Another presenting symptom that they'll have is gurgling. They can have aspiration pneumonia because that food that's sitting there can be coughed up and then aspirated into the trachea because it's still near that area, near the trachea. And so it could lead to pneumonia. And you also will see like some type of dysphagia or obstruction. Like the patient says that there's food stuck. They have a sensation of the food being stuck in their throat. Okay. The most common patient is going to be an older male. All right. So remember that. Once again, it's a false diverticulum, and remember that cricopharyngeal motor dysfunction is the cause of it. All right. Next is going to be Meckel's diverticulum. Meckel's diverticulum is a true diverticulum. This is very high yield. Okay. And true diverticulum, remember, it means that it contains all three layers: the mucosa, submucosa, and the muscular layer. Right. Now, it contains the Meckel's diverticulum. It's true diverticulum, but it contains ectopic tissue, specifically gastric tissue, like acid-secreting gastric mucosa, and pancreatic tissue. So it contains stomach tissue and pancreatic tissue, which is very key to understanding Meckel's diverticulum. That's one very high yield thing that you should know. It's very common in congenital anomaly. It's the most common congenital anomaly of the GI tract. And the patient presents with hematochezia, okay? Very important to know that. Right lower quadrant pain. They can have intussusception, volvulus, and obstruction near the terminal ileum, okay? So keep that in mind. Now, painless rectal bleeding or painless hematochezia is very common. The reason that occurs is because you have gastric acid, right? Because there's gastric acid producing tissue in Meckel's diverticulum, but it's being produced outside of the stomach. So it's going to start pouring into the actual small intestine near the terminal ileum and causing kind of erosions and bleeding. And so that's why the patient gets painless rectal bleeding, all right? Now, the most common cause of intussusception is Meckel's diverticulum, okay? Now, remember, it contains ectopic gastric mucosa causing potential painless lower GI bleeding. So all that is very important. The way that you diagnose it is with technetium 99 pertechnetate scan, okay? And it's just if you see uptake by by gastric mucosa that's not near the stomach, it's like near the ileum, then you know that there's Meckel's diverticulum. That's diagnostic for it. The rule of twos can be helpful to me. I don't really think about it, but it's something that you can get pimped on and something that can be helpful for question stems. It's 2 times more likely in males. It's 2 inches long usually. It's 2 feet from the ileocecal valve, and 2% of the population are affected by it. It presents usually in the first 2 years of life and may have 2 types of epithelia, which we discussed, gastric and pancreatic. All right. So one more time, main takeaway from Meckel's diverticulum. True diverticulum containing all 3 layers. Okay. It's the persistence of the vitelline duct. They want you to know that. It contains 2 types of tissue, ectopic acid-secreting gastric mucosa and pancreatic tissue. It's going to cause painless hematochezia, right lower quadrant pain, increased risk of intussusception, volvulus, and diagnosed with technetium pertechnetate scan. All right? Keep all that in mind and you should be fine for Meckel's diverticulum.